be speaking on advocacy planning to target the goal of eliminating corneal blindness by 2030.
Sorry about the change. There is a, I don't know, there's a heavy clash, especially for this 9 to 10:30.
I have also a class, so I have to, by
So
10 I have to go. Anyway,
I would be
time.
talking about advocacy and policy planning to target the goal of eliminating corneal blindness by 2030, and much of it is a part of presentation that we did for CRO in the Southeast Asian region. And India has been on the forefront, I think, and everybody knows that NPCB was started in 1976, and then WHO launched Vision 2022-2020 program. And cataract remains the leading cause of blindness, and of course in the latest survey it has been very clearly shown that corneal blindness is second to cataract, and in the younger age group probably it is the commonest cause of blindness. So if we look at the global distribution of blindness and visual impairment, there were 48.2 blind people in 1000 per million population as per the CRO, and in India you have about 53 million. Again, I think everybody is aware of this, which shows the leading indication for corneal transplantation reported by the 98 countries. And for us, it always has and been infectious keratitis, whether it is healed or whether it is active. Now, the sustainable goals, the United Nations Sustainable Development Goals for any program or for visual program is that in general, the poverty reduction has to be there, economic growth has to be there, employment to education, gender and reducing inequalities should be there, and it should be whole of the government approach to vision and include eye health in their implementation of sustainable development goals at the national level. Now, these were in fact studied in relation to CRO, but they do apply to India that I've talked about, and so good health and well-being is the way to go. Then of course quality education is required, and reducing the inequality is also very important. Now what has happened is actually there has been a difference in the availability, accessibility and acceptability of the eye care system, and in many countries including ours, eye care needs are greater in rural areas, but services are only provided in the hospitals in the urban areas, and this thing even shrinks much more for corneal blindness. Now there are various innovations and strategies to address the challenging of corneal blindness, and one would be in terms of availability of donor tissue, and most of us are doing, but this still needs to be widened further, and that is networking with the eye donation centers, hospital-based corneal retrieval program, awareness generation activities in the community and educational institutes, and initiation of a toll-free number which is there in place but possibly does not work everywhere, and of course adoption of the in situ corneal remixation which is there in almost 90% of our eye banks now. Long-term media preservation is required, and we've come to intermediate term, but I think long-term is something where we can focus upon, and we all are doing one cornea for more than one recipient, and of course we should develop protocols for problems that can occur after a graft, because whatever has been done has to be preserved also. Then maybe we will have to look at our priority list again and include the fellow eye status also, which most of us, some of us do use, but many of us do not use. And shortage of skilled corneal surgeons is there. The training program for surgeons in keratoplasty is required because of the pandemic. This again took a toll. The research of the eye banking has to be again revamped completely, and one has to explore of synthetic constructs and other available modalities as an alternative to corneal transplantation. And I think something that is what we are lacking, we don't have it as we would want to, is the cornea transplant registry, just like the other continents and other countries have registry like Australian registry. Uh, Availability of the law related to cornea donation is available in all CRO countries including India, and policy changes are required favoring the corneal donation, and one is the we've talked about it a lot, but it still has not materialized, and that is the mandatory the required request law and the mandatory death notification. So all should be notified to the nearest eye bank for eye donation counseling, and required request law is something which again needs to be reinforced, in which is not there in our country. And I think first person consent makes the decision. Who makes the decision to the organ or tissue donor legally also needs to be changed, and this can change the number of the donor dramatically, as the pledges will actually convert into donations. So somebody who's already pledged should automatically convert to a donation. Access to all, I know that we do have access to trauma centers or mortuaries, but that is at our discretion. Those IBanks who want get access, but it should be the other way around, that all trauma centers and all mortuaries should be actually linked to the IBank, and which should form a network, so that the eye donation counselors can facilitate eye donation. Then another thing is that the telephonic consent, if it is given a legal status, like a call center approach, will be useful to counsel the family members, and this will directly impact the actual number of the donation. And of course, partly this has been done, but the cost coverage of the cornea donation should be much more than what it is there right now, and what is desired is in fact several times or several folds greater. The National Donor Registry is something again that we have to look into, which has not been done, and National Waitlist Registry would be the way to go, and so EBI, NOTO, NPCB should form a nodal agency to maintain such a registry. Now, if you look at, this is just comparison of the various Southeast Asian countries as to what are the issues adopted by the select countries, and this also includes India, and we are primarily lacking in the registry and the mandatory death notification. Now, the government has done a good thing, and I think amendment of the Central Motor Vehicle Rule in 2018 is indeed a laudable step. But even this can be also linked not only to the driving license but also to Aadhaar card, and because this is the most frequently used document for identification of purposes, and this de facto will become the National Donor Registry. And this information about the intent of a donor will flow to the point where the knowledge is actually useful and where it can be utilized. Now, this is just to show how we did try to advocate the same, and this was also published in Indian Journal of Ophthalmology. There are various key factors for successful advocacy. It is important to do high quality research, to generate data so that you can do advocacy, to make it in a position so that you can help the government to change the policy, and one has to be accessible to the policymakers, and one has to be interacting with them constantly. Again, it is important to build relationships, to be entrepreneurial, and to reflect continuously on how you should change your strategy, or what should you engage, what you should want to do, and what is working. So to conclude, the potential of cornea donation and transplantation has yet to be optimized, and the control measures through policy do exist, but they need enhancement further. And to resolve the problem of corneal blindness, countries need to fast track their own policy changes, including our country, and a well-designed regional governance framework needs to be put in place to coordinate the individual national efforts in matching the supply with the demand. And the more organizations they come together, the message goes further and disseminates amongst each other. Thank you very much for your kind attention.
Thank you, Dr. Namrata, for a very nice coverage of the topic. I think advocacy is key as far as iBanking is concerned, and advocacy in relation to policy, that is, I guess, the way to go, I think, maybe.
I think we have Jashwant Bhai here, who has made a video film for this same purpose that Namrata is talking about, that advocacy, and we need the required request and the mandatory consent provision. If you want to show the film now, you can do it now. You have the film with you.
It's with Namrata.
You have the film?
I'll send on WhatsApp to you. I have got it otherwise.
Any comment on this? Yeah, Dr. Sujata.
I think this should be revisited about the water transplantation center rules. Because the water transplantation center says that you should have a specular. I raised this issue.
That's the terrible.
You should have a specular per patient. But not all people who will have specular.
Yeah.
So I think that needs
See,
to
we
be
discussed this
revisited.
about in Pune a couple of
Yes,
years
I
ago
remember
with
that.
Dr. Radhika, and that time
Yes,
they
yes,
had
madam
felt
was there.
strongly that it is desirable,
Yeah.
but not it should
Now it
not
is
be
mandatory.
mandatory. But
Yeah,
the
it is
issue is that
mandatory.
many of these
No,
states are making it mandatory.
Yes.
but the other thing is
Specular
specular,
microscope.
specular. But the other thing is, yes,
Spe- specular microscope is mandatory for a transplantation center. I think it should not be mandatory.
I totally agree with you. Dr. Azad was in charge of the committee, and that time there was this decision, and I had strongly said that it should not be. But the experts at that time felt that it is required. Generally, what tends to happen is the problem happens is because some people want to exclude other people from doing
Yeah,
things.
yeah,
The problem is not with the authorities, the problem is with us.
yeah.
It is us ophthalmologists only who are the problem.
But-
We need advocacy
So we need
get
to
that
have
word
advocacy.
changed
Yeah,
to
it's not
desirable,
required.
not
Exactly.
mandatory.
There's absolutely no need for corneal transplantation center to have a specular microscope as a mandatory requirement. However, what the government will be prepared to do is have a new chapter, and we can easily change this in the rules. Form 15 can easily be corrected. It's not a problem at all. So it can easily be done, and it should be removed, I feel. It should be made desirable. It should
Desirable,
not be,
not
yeah.
mandatory.
For a
No,
corneal
but the-
transplantation center. For an
there's a
eye
catch
bank,
in
it
that.
should be
Yeah,
mandatory.
I bank it should be
Yeah,
mandatory.
for eye bank,
Yeah.
it should be mandatory. For corneal
No, no,
transplantation
but,
center,
no, but
it
there's a
should be
catch in that, ma'am.
desirable.
You can have a sort of a MOU with any other center
Yeah,
which is
that's
having
understood.
specular. So that can
That
be
is
done.
understood.
Unfortunately,
Yeah.
many states don't allow this. Yeah.
Okay. Okay.
You should say access to a specular microscope. Otherwise, in
Yeah.
one city, you'll have 5 specular microscopes, which is a waste
Yeah.
of resources.
Yeah.
So we should have access to a
Access
specular
to- yeah,
microscope for
yeah,
an eye bank. The other problem is those eye banks who don't have a specular microscope, they again don't want to be called eye donation center. So the problem is us only actually. It's not with the authorities. It's no, it's easy for you to say that, Manisha, but you go to the peripheral area, there are places like, for example, Pondicherry, there's Ames Pondicherry, there is also Jipma Pondicherry, there is, there are 3, 4 other eye banks there, and they're all functioning. Now, do you want them to shut down, or do you want them to change their name to an eye donation center? It's not, it should be that they can share the resources, no? For a long time, you shared the specular, right, in Venu, isn't it? So, yeah, you have to think
Yeah.
back about the journey, and the
Problem
question
is
is
when
to
you put
nurture.
it down like this, and
Exactly.
states have to implement. States somehow are so
Yeah.
rigid that they are more rigid than the center most of the time. So
Absolutely.
they pass their own laws. I mean, Maharashtra has passed a ridiculous law which is only applicable to Maharashtra, that I cannot export even a therapeutic grade tissue out of the city, out of Maharashtra.
That's another thing which should really be stopped. Yeah.
Even for research purposes, I can't send a cornea out of Maharashtra. I can
And
receive.
sir,
Yes,
there
Shakti.
again, sir, it is an ophthalmologist in charge who has done this.
Yes.
So honestly, I don't know what we are talking about. It's a very senior ophthalmologist who has got that rule put. So what are we to do?
We tried our best to get
Yes.
it changed.
Now we are going to the court.
Yes,
He's
I
filing
think
a court petition.
absolutely.
Mental illness is
I agree with you.
Actually, we had provided 9,500 corneas which were not viable to transplant for research training all over India. And then all of a sudden, out of a blue, the claim circular came without any consultation with the eye donation center or eye bank or even ophthalmologist. And it has been so strictly enforced that when I tried to oppose it, they did everything possible to see that my eye bank gets a court order to stop my work.
Quite right, because it is not a commodity. The cornea is not a commodity. It is a donated tissue to be transplanted, and there's no point having an artificial barrier like that.
Shakeen
So
wants
it
to
should
say-
be removed.
Yes.
Just wanted to
No,
make a
just
point.
1 second. Yeah.
So then another issue, if one cornea surgeon operating one center is approved cornea surgeon, can you pay at the second center where you can one surgeon operate at 2 different places?
100%.
I think, yeah.
You see, at least in Maharashtra, center is recognized. For example, I have a nursing home, private nursing home. My nursing home is recognized as a corneal transplant center. From my nursing home, I've given a list of 5 doctors who will operate. I've given their certificates, and also they've got a list internal with them. but on the certificate, no name of doctor appears. So that same doctor can be registered in 2 or 3 different centers as well, which is happening in Maharashtra. That is the issue.
Sir, not as a full-time ophthalmologist, as a part-time cornea specialist. He can work in different centers.
We are supposed to get our other eye bank renewal.
Yes.
They refuse it on the contest that you have already registered somewhere else. So the second center will not be agreed.
That is the problem with officers who don't understand that the same surgeon can operate.
Can we have some guidance from doctors who can direct the concerned officer?
Actually, it's there in the, if you say the form 15, it says one full-time corneal transplant surgeon, one has to be full-time,
Yeah.
and that one full-time cannot be full-time in 2 places.
Correct.
Yeah.
Only one.
So, one full-time corneal transplant surgeon and one part-time.
We have registered 3 cornea surgeons registered with you.
Yes.
You can pick up anybody from there.
Pick up one. Make,
No, but
make
if that
person
one
who's not going
person has to
elsewhere
be
full-time.
full-time. See?
No,
see,
part-timer
supposing
can
we
go
have to-
elsewhere as
Yeah,
full-time.
part-time can go to many places.
Medical college, we are 5 faculty members. So all of we are operating there. All we have been registered with the state authority. And 2 of us has their own, corneal
Yes.
transplant center.
So
But they have
out
refused it
of your
now.
5, the one who is not going anywhere.
They are refusing that too. That's what my question
Yeah,
is.
yeah. So out of 5, there are only 2 who are going elsewhere.
Exactly.
So वो दोनों को part time बना दो, आपका full time, तो बाकी के 3 में से keep one as a full time
But
person.
they're not letting that happen, you see.
So
I'll tell you what the problem, sir, is saying is that surgeon A is operating in one place and the same surgeon is going to be full-time in another place. So that they will not allow,
No.
right? So, so therefore you have to operate only in the place where you are full-time. If you want to operate in basically it means if you're full-time in one place, you're not expected to be operating in another place.
Correct.
Whereas I feel even this rule can be relaxed. It's not required because there's a shortage of
Shortage of
corneal
surgeons, we
surgeons.
need the
It's
surgeons.
ridiculous. So these are the 2 points which can easily be changed in the rules. It is not an issue. I think we can just write these points that we should give this clarification. In areas where there's a shortage and particularly in government setup, you have to encourage. So if you, it should be that if you're full time in one place, you can, if you have the time, you can go to the other place. No problem, no problem.
yes, 100% agree.
You may have enough cornea, but we need more cornea surgeons.
To rectify that, we
Exactly.
have to amend the rules.
Yeah.
So this will have to
Add to our rules for amendment.
Actually, it's just the difference in interpretation at different places.
About the restriction of not sending cornea outside our state, as we have lost a golden opportunity. IIPTB was giving us on later the
Vision graft.
vision graph, But then when they say okay, this kind of restriction is there, that would allow therapeutic grade corneas to preserve for
President of Eye Bank Association of India and also